Anne Mackie. I work for the UK National Screening Committee, and I will whip through these partly because I prefer a conversation. So the UK National Screening Committee, NSC from now on, is the competent body to make recommendations to the 4 UK governments about whether screening will do more good than harm at reasonable cost. And I'll come back to some of those as we go. For a long time, I've tried to patent screening, because everybody does screening, but it didn't work. And so what I have adopted is national systematic screening programs. And that is, you start with a cohort that you can identify, and then you find people without symptoms overwhelmingly. You find them at a point when the test predicts something important, you test them, and then you enroll them into head-banging, quality-assured programs, so that ideally, the only reason they don't get what they need is they go, shut up, I don't want it. So that is so important, because an awful lot of this stuff is driven by guidelines, which is not managed in that way. So an awful lot of people, as I get older and my chronic diseases come upon me, I would prefer to be in a position where the machines and the doctors, clinicians look after me in a way that means that I get to say I've had enough and they don't just forget me, because there's an awful lot of people like that. So it uses science and published scientific evidence, yes, international, and we also use, we assess those against the framework of criteria. I think Nick needs, he flashed all his slides up, so we're going to go over those a little bit more detail. But it's a framework. If you look at the rare diseases, we haven't got single RCT in any of them. We use clinical information, we use user information, we use all sorts of techniques to get the best available evidence that we can. We only recommend screening if there's evidence that the offer to screen plus everything else does more good than harm at reasonable cost. And our job is to make good public policy recommendations. That's not the same as a clinician's responsibility to look after every child. And it's really good to be in these sorts of environments where that aspect talks to people whose job it is to find the children and look after them, because they are very different views. I'm a public health doctor, it's all right. Screening's different. It's not health promotion. Stop smoking, it's written on the buses. And it's not clinical care. We write to innocent people in their own homes and go, unfortunately, you appear to be 50, therefore you're at higher risk of breast cancer. Oh dear, you've had a newborn baby. We'd like to offer the state the state would like to test you for 10 things you can't spell. Please feel free to look them up on this website. And they trust us for the most part. Occasionally they really don't, but that's the difference. It's complete, and the ethical position that follows from that means that we have to tell people what we're doing, and we have to offer them a choice. And we don't just force them, even if that was possible. It's end to end. I've done that, given us 15 minutes. So I'm often accused of only considering harms. You only think about harms. Well, it seems to me that we're the only people who do think about harms. So the newspapers, the politicians, the users, the families affected, their representatives have all got in front of them, either in their mind's eye or in reality, a child that was ill. And they know that if that child was found earlier, they could have helped that child have a better outcome. Absolutely get that. It's extremely important perspective. What I've got to do is help everybody understand, I think as Annika said, we've got to go through 600,000 babies a year to find them. And if we hurt 10,000 in the course of finding 8, we need to look at that properly and say, is that okay? And that's what we do. So we've been pushed into talking about what kind of harms there are. False positives, Annika's covered that slightly. Overdiagnosis, sorry madam, your child has got this. But it turns out it doesn't. Now, some people say that's good because you get that rush of happiness when your child hasn't got the thing. but we do know that some people carry on and continue to not believe, because the first test can't be different from the second. And there are uncertain results, which I think Annika has also talked about. There's a lot of talk about diagnostic odysseys, back to we could have found this child earlier, but there aren't many about therapeutic odysseys. We found this child, and it's going to take an awfully long time to find out whether it needs the treatment or not. You're welcome to have the slides, by the way. And of course, one of the things these things do is draw money, healthcare resources from other things we could do with the money. So neonatal intensive care, neonatal nurses, postnatal care on maternity services. Those are all things which are asking for the same bucket of money, which, if the newspapers are to be believed, is running short. So there is an opportunity cost, and that's why we do the reasonable cost thing. If we think we can spend the money on something that will get us more health benefit, that's the advice we should give. And we use NICE as the kind of benchmark for that. Blood spot screening, very high levels of public support. Currently we do 10. We're part way through implementing tyrosinemia. Uptake is extremely high, but reviewing the case for adding extras is really difficult, and we'll go over that a little bit more. So we are currently wrestling with SCID, which the NHS England have been trying out for the last 3 or 4 years. One of the things we've tried to do in the newborn blood spot system is say we need more evidence, and the research community has not come with research proposals, so we've had to do them ourselves. So in SCID, and hopefully in SMA, we will do direct evidence gathering in the national service, and I think that's the way we're going to be able to try to get through these things. And we're currently cooking up a scheme to see whether, when Ellen turns up with, oh, I can find you another 200, oh, that's nice. Here's the approach we might think about taking, and we've been talking to people about that. A lot of it about. So the potential benefits of whole genomes are early diagnosis and treatment for more babies and better outcomes and quality of life for babies. But there are potential benefits. The programme as it stands is essentially finding out whether it's possible to get and test this number of genomes. The things they're looking for are rare, and therefore we're extremely unlikely to find out whether the babies have benefited from that. And that's part of the conversation we're having with GEL about how can we assess the follow-on and whether those babies have benefited. Should we do is the test better? Should we abandon the proteins that we test for at the moment? Should we just go to the genes? Or should we say the genes aren't useful in this circumstance? Or, as we do in the cystic fibrosis programme, use the genes second. We find the naughty protein and then we test the genes, and then we say, fine, that baby's likely to have the problem. And that's just for the blood spot. What about hearing or cardiac conditions? Because we also screen for those. So at the moment, the tests arrive roughly the same sort of time, and we've had a play. I think somebody has had an abnormal blood spot and an abnormal genetic result on the whole genome. So we've had a go at that. So for us, there are challenges. How should we assess the benefits and harms of hundreds of conditions? Is average benefit okay? So if your baby is found to have 1 of 200, is it okay that it might, if the average is better, but your baby happens to have the thing that is subsidising the benefit in something else, is that okay? These are not questions for me, but they're societal questions. We need to retain the high levels of public trust in the newborn blood spot programme. It finds and prevents severe intellectual and physical disability in lots and lots of babies every year, and if we undermine that, then we will have done harm. As Annika says, there seems to be this thing that genes are better than anything else. So will parents think they've already been tested with these things? So there's a business about whether the gene actually predicts the condition. Anxiety for parents. and the opportunity cost. These tests at the moment are not cheap, whereas I'm reliably informed that adding a new condition to the blood, adding a new protein to the blood spot, is it 50p still, Jim? Yeah. It's always been 50p. It's mysteriously like the nice thing, which hasn't shifted from 20 grand, has it? Despite it being available for 30 years. Anyway, Annika's done this, I think. Oh no, so we did a piece of work in cystic fibrosis. So if you do follow-on genetic tests, you can make the test more specific. Your baby really has got CF, but we might miss some cases. Or you can make it more sensitive. We think your baby's got CF and not miss any. And we asked people what they thought. And to our utter astonishment, quite a few thought that there should be more specific. So the anxiety about these uncertain results was more important to them than I had thought. But that took quite a long time and quite a lot of conversations. It takes people quite a long time to work through that. Might be the effect of having a small baby and no sleep, of course, but nonetheless, that's an issue. So what we are trying to do is square this is very exciting, we have no evidence. So what we're going to do between us, if we possibly can, is develop a process to gain evidence. So we're thinking about a mechanism by which we can add serial conditions to a kind of data methodological program and say, right, let's see what happens to these babies. Well, what's happening to those babies. And that will require massive linked data, and we need to think about the methodology. Observational research is all very well, and we need comparators as well. So we're thinking about those things in order that we can try these things out at scale. We're going to need all 600,000 babies for the majority of these, I think. But we will know after a period of time whether it was a good idea and in which babies it was a good idea. And that seems absolutely critical to me, as well as knowing how the babies are getting on. We screen for 10 things at the moment. We do not have even the bare minimum of, is the baby okay? Has it got its own liver? Did it go to school? And that, so we don't even know whether we're helping the babies that we've got, let alone whether we're helping them more than the babies we didn't get. And that seems to me to be a critical piece of this jigsaw. So we are calling those in-service evaluations. It's a verb, not a noun. We're trying to evaluate things in live services. And we've done one of those for severe combined immune deficiency and hoping to do one of those for spinal muscular atrophy. I've talked about this platform. I got ticked off for calling it platform, a mechanism to add serially lots of conditions and see how the babies are getting on with comparators and link data out into social care or ongoing healthcare. And that will include things like comparators. So we should have all the blood spots in a fridge. Ellen's got tons of walking biobanks. So if we are asked to do a test on somebody because it's screening for a terrible condition, when we go to a live group of people who are 50 and they've all got the gene, we go, maybe you need to fiddle with your test because it doesn't seem to be too bad for people. But if we go and find nobody, then we go, that's interesting. So maybe it was, so we can start to tweak the tests or understand a bit more of the prevalence or the penetrance of the test into illness by using comparators, and I think that's going to be really important. But that's going to need, I've called it manage access to screening, so that combines doing these in-service evaluations in very large groups of people. So for the most part, the public will just think we're screening. Keeping an eye on what's going on, so we can say, stop it, tweak it, carry on. But we're going to need very clever methodologists to understand how we do that, because it won't be randomized. I'm astonished if it be randomized. And we need really proper links into healthcare, social care, education data in order to work out how these babies are getting on. So it's a good idea, but we've yet to nail it or sell it to NIHR. only a matter of time.